for children from. He will be talking about basics of BMT in children nursing perspective. Hi, Dr. Amreen. Can you hear me, please?
Yeah, hi, Richa. I can hear you. Thank you.
Yeah. Please. Yeah. Pleasure to have you here, Dr. Amreen. Please share your slides. And while Dr. Amreen is sharing her slides, I will introduce the next speaker who will be taking the talk immediately after her. That is Ms. Mahalakshmi, who is a staff nurse in the BMT unit at Apollo Hospitals, Chennai. She will be talking about nursing care of children undergoing BMT. Dr. Amreen, over to you. And to all the people attending the webinar, please post your questions on the chat box and we will take them up after the individual sessions. And we welcome questions and queries, and we hope it's an interactive session. And thank you very much for being here. Over to you, Dr. Amreen.
Thank you, Richa. In case I'm not audible, just let me know. Thank you for inviting me to give this talk. I'm going to try and cover just basics of bone marrow transplant. So what is bone marrow transplant, and is bone marrow transplant even the correct terminology here? What we are transplanting is not bone marrow. What we are transplanting are hematopoietic progenitor cells or stem cells. And what is a stem cell? A stem cell is something which can, of course, divide and produce B cells, T cells, NK cells, neutrophils, RBCs, platelets. But importantly, has the capacity of self-renewal. Now, what does self-renewal mean? It basically means that they are able to multiply and produce more stem cells. And where are we getting these stem cells from? We can get them from the peripheral blood if we mobilize it from the marrow or the cord blood and the bone marrow. So what we're trying to do is transplanting or simply transfusing stem cells which are derived from peripheral blood, cord blood, and or bone marrow. And the two kinds of transplants here, this autologous transplant, where we are taking these stem cells from the patient, storing them, giving chemotherapy to the patient, and returning those same stem cells to the patient. An allogenic transplant. In allogenic transplant, we're taking stem cells from a donor. A donor can be unrelated, related, or from the cord blood. I'm going to try and talk in more about allogenic transplant here and what kind of donors can we use for allogenic transplant. Of course, the sibling donors, so sister or brother, unrelated donors, so anybody from the bone marrow transplant registries, a haploidentical donor, which is a father or a mother, which would be a half match, or an umbilical cord blood, which can also be a match. And how do we decide which of these donors to take? So that's depending upon something called as HLA. And what are HLAs? HLAs are genes which produce something which is called as a major histocompatibility complex, or the MHC. Now these MHCs, as you can see in this cartoon here, what they do is they will show our immune system proteins. These proteins can be either foreign proteins, like for class 2, or self proteins. So matching these become very relevant to prevent graft versus host disease. So we try and match two classes. So you've got HLA-A, B, and C in class 1, and DRB1, DQB1, and DPB1 in class 2. We don't always use DPB. Now, what are the conditions that we use stem cell transplant for? So simply put together, when we're trying to replace certain cells, so thalassemia, when you're trying to replace the defective red blood cells, or metabolic disorders, where you're trying to replace enzymes. When you're trying to rescue a dying marrow, in case of aplastic anemia, when there is a relapse of some kind of cancer, blood cancers like leukemia, and when you want to re-educate the marrow in case of primary immunodeficiency. I'm going to go through one transplant as I go through explaining what BMT is, so that you get a better understanding of how the process is done. So we've got an 8-year-old boy who was referred to as refractory AML. Post-induction, he had 86% blast. He developed cardiac dysfunction during the second chemotherapy. So his ejection fraction had gone down to 30%, and he needed 4 cardiac supportive medications. At this point, he was referred to us. We gave him 2 cycles of chemotherapy, post which he was MRD negative. He had no sibling and he had no match-related donors, and he had a 10/10 match unrelated. So we've got an indication for transplant here. He has refractory acute myeloid leukemia, and we've decided to donor here, which is a full match unrelated donor. Okay, so let's start transplant. The first aspect, and a very important aspect, is preparing for transplant. So what you're trying to do here is evaluate the patient. Is the leukemia under control? If there's an immunodeficiency, are those infections under control? If it's a thalassemia, is the iron status well? So evaluating a patient, getting the patient fit for transplant is an important aspect. Then the second thing would be evaluating the donor. Is the donor fit to donate? Other than evaluating the patient's disease, we also have to evaluate the patient's organ function, like an echo for the heart, cardiac status, ECG, and an ultrasound. And a very important aspect, I think here is where nurses get really involved, includes counseling of caregivers and children and answering their doubts. So in our patient, we have done a disease evaluation. We know he's got remission of the leukemia. An important aspect of evaluation for him becomes cardiac because he was on 4 cardiac supportive medicines. So we've got him evaluated from the cardiac perspective. His echo looked fine, cut down on his cardiac supportive medicines to 1. And counseling of caregivers. Now they've come to us from Odisha. They've come for the first time in a new city like Mumbai. Of course, they're a little overwhelmed. And the child is not very, very small. He's 8 years old. So it's important to understand what he understands about the disease and what does he understand what is going to happen to him during the process of transplant. Now, when we start transplant, there are 3 phases of transplant. One is the pre-engraftment phase, which includes conditioning to engraftment, somewhere around day 30. The post-engraftment phase, which is day 30 to 100, and the late phase, which is day 100 to day 365. Most of the patients you encounter with as an inpatient would be in the pre-engraftment phase. So we'll start with the pre-engraftment phase, which basically begins with conditioning chemotherapy. Now, conditioning can be chemo or radiotherapy, and they classified in simply as minimal intensity conditioning, reduced intensity, and myeloablative. Myeloablative meaning the strongest chemotherapy that you could give in transplant. Reduced intensity is slightly less, minimal intensity is more or less. Along with chemotherapy, most of these children will also get something called a serotherapy, which is alemtuzumab or ATG. Now, just to give you an example of how a transplant schedule looks like, so this is our patient, which we've discussed. So day 0 is when he gets the stem cells. Beyond that, the chemotherapies are numbered in negative. So day -1, 2, 3, 4. So as you can see, his chemotherapy starts on day -7. It gets over on day -3. And if there are any GVHD prophylaxis like methotrexate, they can go beyond day 0. When we're giving chemo and radiotherapy, this is something I guess you would be aware about, looking at side effects of nausea, vomiting, fever and rash more common with serotherapy like ATG. And this may restrict the nutrition in the week of chemotherapy. Recognizing and preventing toxicities becomes an important nursing aspect, being able to understand how the patient's intake and output is, how their hydration status is, are they having nausea or vomiting, and do they need any other supportive prophylaxis. Post-chemotherapy, of course, what we would see is mucositis. We're all aware about the WHO grading scale for mucositis. But during transplant, the mucositis may be a little more severe than what we see in hemo, and the complication of mucositis may also be a little more significant, which include pain. They can have oral infection like oral candidiasis, oral HSV, oral bleeding with thrombocytopenia associated with it, loss of taste, so may not want to eat, which affects the hydration and the nutrition, fatigue, and systemic infection, including sepsis and neutropenic enterocolitis. So in the case of our patient, he had grade 3 mucositis. He had mouth ulcers, he had difficulty to swallow, and we had to give him total parenteral nutrition, analgesics, but he was able to sleep undisturbed. When examining the mouth in case of mucositis, it's important to look at all areas and ensure that there is nothing significant in all those areas. Now, post-chemo plus minus radiotherapy, whatever is given, the second step would be giving the stem cell. The stem cell infusion is like any blood product infusion. Very important to see that are you giving it to the right patient, the right graft? Is the volume correct? And has it gone for the appropriate duration? This is an example of how a stem cell graft looks like, little less red than what a packed cell would look like. So our patient tolerated the graft infusion very well. Now we've given the chemotherapy, we've given the graft. The next step is mainly, I would say, nursing care. So you're just looking after the patient till he starts to engraft. And what is the most important aspect here would be infection. So if you look at this lovely chart, which is which is published in the EBMT book, infections by gram-negative bacilli and gram-positive organisms are more common during the pre-engraftment phase. And these are very important to identify early, pick up, understand, because they can be fatal in these children especially. The viral infection is something which you would see roughly, usually post-engraftment phase, that's day plus 30 onwards. Now, where will they get these bacteria from? You've put them in a HEPA filtered unit where you're making sure that the air is coming in clean. The rooms are generally very clean. So what we're focusing on here is bugs which the patient has. So on the skin, in the gut, and most importantly, hands of healthcare workers. So I'll just go through how we try and manage this. So how do we prevent the spread of infection between the patients in the hospital, and not necessarily infection? It could just be that the patient has a resistant bug and it should not go to the other patient. So we test them for resistant bugs before admission. We have a checklist on admission prepared by a nursing staff where they can identify what bugs this patient has, what kind of isolation precaution does he need. And very importantly, these details are visibly displayed so that nobody forgets what which patient has. So this is an example of our pre-admission checklist. We're looking at certain parameters to see whether they've been tested for them. And this data of our pre-admission checklist made by a nursing staff was published by them recently, where they've tried to see if we do implement isolation precautions in time, does that prevent spread of infection in the unit? So going back to our patient, he was MRSA negative. His nasal swab, which we do routinely for respiratory multiplex PCR, was negative. And he was found to have carbapenem resistant in his stool isolation. So now we know he's got carbapenem resistance, so he needs to go under contact isolation precaution. This is an example of how we do contact isolation precautions. As you can see, these are gowns here for contact isolation. There's a sterilium here, and there are gloves here. And on this board, there is a note there is the WHO format for contact precautions. And we display this information very clearly here. So anybody who enters the door is aware of what is the patient's infection state. Once we know what the patient has, so now we know this patient has carbapenem resistant bug, we need to remember that early recognition of sepsis here will be very useful and helpful in reducing morbidity and mortality, especially in these patients. And how do we recognize sepsis early? Again, it's primarily nursing assessment. Nursing assessment of a neutropenic child when they have fever, their vital status, their blood pressures, the tachycardia, how active they are, how lethargic or irritable is very crucial in being able to recognize sepsis early. An important aspect I think we do know is that vital monitoring in children is very different from adults. Your BP centiles are age-based, your heart rate and respiratory rate are also age-based. Some of the other complications which are nursing care guided, important here would be hypertension, because we do use cyclosporin and other nephrotoxic drugs for preventing graft versus host disease, which are notorious to cause hypertension, which again is nursing care led, picking it up in time and starting antihypertensives in time. Another complication of transplant is veno-occlusive disease or sinusoidal obstruction syndrome. Simply put, basically the chemotherapy or the radiotherapy which we give with the antecedent disease the patient may have can cause hepatic toxicity. The only reason I've included 2 lines about it is because this hepatic toxicity, one of the first manifestations of it would be fluid retention. So daily weights, twice a day weights, being able to pick up that the patient has fluid retention and then looking for, is this secondary to something which is alarming, becomes very relevant, especially because If we pick it up early, treat it early, it has a very good outcome. Again, the last thing would be bleeding, which can be secondary to thrombocytopenia and mucositis. So going back to our patient, we've put him on a cardiac supportive medication. He was continued on that single drug, had no issues in terms of cardiac during transplant. He had one episode of gram-negative bacteremia, which we were able to manage with antibiotics. He had no veno-occlusive disease, a significant bleeding episode. Now, once they've come closer to their neutrophils coming up, that phase which we call when their graft is recovering is known as engraftment. So neutrophil engraftment means neutrophils going above 500 cells, and platelet engraftment means being independent from platelet transfusion for at least 7 days with a platelet count of more than 20,000. So our patient engrafted neutrophils on day plus 14 post-transplant and platelets on day plus 20. Once they've been grafted, the next complication which would be concerned about, which we want to monitor for, would be acute graft versus host disease. So basically, what is acute graft versus host disease? In simple words, it means that those cells we've put in have recognized that this is not their body, it's a foreign body. And when they recognize this is not their body, they start attacking that body. When they start attacking their body, the three areas which are most commonly involved. First, skin. Most cases, sometimes it can start with gastrointestinal tract first. So it will be skin, liver, and GIT. So how will it present with skin? So most often there are erythematous rashes, which can start on one side and involve the entire body. In GIT, there will be anorexia, nausea, very subtle sign. Children stop eating, don't want to eat anymore. And very common and important sign would be diarrhea, which is typically watery. And in the liver, there would be cholestasis, so there'll be bilirubinemia and enzymes which are elevated, which you will find on blood test. In terms of nursing care, it becomes important here to pick up any rash which is present on skin and any change in appetite or stool output or stool frequency, which helps us pick up graft versus host disease early. Now, we know the patient has engrafted. He's had no GVHD, he's doing well, he has got no viral infection. Now we're about to discharge. And talking about discharging him, and the most important aspect here is just completely about nursing care. It's nothing which we as doctors are actually involved in. So, discharge planning, this is how we do it. We ensure that the patient's mother or father, whoever is with the child, understands medication administration. They're going to go home on a lot of medications. They need to know when to give, how much to give, and be able to give it correctly. Most of them go home with a line, which is usually a Hickman line or a PIC line. So they know or understand how to take care of the line at home. They understand hand hygienes, what precautions to take at home, and very importantly, when to go back to the hospital. So this is an example of how we do a medication chart. So just to make it easy for the patient's relative or the mother or father to understand, we do it time-wise. So if you see here, we've got a list of all the medication he's going to take, but we've put it in order of time. So the mother, it's easy for the mother to understand these are at 8 a.m., 9 a.m., 10 a.m., instead of doing it 3 times a day, 4 times a day, twice a day. We also try and explain them that how to keep the home clean and dust free, not to vacuum and dust the room when the child is present, and how to clean the bathrooms. A lot of our discharge planning instructions are given by a nursing staff, and they also go home with documents. Almost all centers would be having discharge instruction documents with the patients are asked to carry with them home, which basically explain them how to take care at home, when to come back to the hospital, most importantly, emergency care instruction, and also what to look for in the child at home. So a patient got discharged from the transplant unit quite soon, and he's doing well on follow-up 6 months post-transplant. That's all about the case I wanted to discuss, and just briefly about basics of transplant. I would like to thank our amazing nursing staff who's been really vital to the care that we provide to our patients. Thank you.
Thank you, Amreen. That was a wonderful overview of how allogeneic transplantation works in children. And you're very right that nursing care is essential to have a good outcome here. So I think we'll have some questions in a bit. Right now, there are no questions, but please stay tuned in while we start the second talk. That will be by Ms. Mahalakshmi. Mahalakshmi, can you hear me, please? Hello. I can see her logged in. Um, can you hear me?
Yeah, yes, ma'am.
Yeah, hi, welcome. And over to you for the nursing perspective of children undergoing BMT. Please, if you can share your screen.
Yeah, okay, ma'am. Good evening to everyone. I am Mahalakshmi, working as a staff nurse in BMT unit at Apollo Cancer Center, Chennai. I am here to share some ideas about the care given for BMT patient. Nurses lead the process and tend to patient daily needs. This include preparing patient for treatment of PPSC transfusion. We will do pre-BMT workup for patient and donor. For patient, we do some investigation like chest X-ray, ECG, lung function test, bone density scan, bone marrow biopsy, and some blood test are do for pre-BMT patients. Then for donor, administer injection nuclein for once a daily for 5 days and monitor CBC day 3 and day 5 on receiving of injection nuclein. Administering a high dose of chemotherapy and radiotherapy. We are commonly using chemotherapy drugs are triosulfan, fludarabine, methotrexate, busulfan, melphalan, and cyclophosphamide, triosulfan. During administration of chemotherapy, frequently monitoring of patient vital signs and fluid and electrolyte balance. Administering high dose of hydration for patients who are receiving injection cyclophosphamide before and after the receiving of chemotherapy to prevent bladder toxicity to patient. Monitoring of blood count regularly, which is especially include PT, APTT, INR, renal function test, and echo for patient who are receiving injection cyclophosphamide. Compulsory 3 times sponge bath also given for who are which patient are receiving injection triosulfan also. Then we are providing neutropenic diet for patient, which food include packed curd, double boiled vegetables, potatoes, carrot, peelable fruits like banana, orange, and pomegranate, packed fruit juice, purified boiled water, lactose-free milk, well-cooked soft rice are allowed our patient, and also some semi-elemental diet like Fantasure and Cryptic Pup liquid diet only will allowed our patient. Then performing assessment and physical examination include weight and abdominal girth monitor twice a daily, monitoring vital signs and IO balance closely and hourly will monitored. Monitoring of skin integrity, soft tissues area and oral care regularly and daily basis. Providing central line care for patient, we are changing bionectar of every alternative days to prevent infection to the patient. Dressing done in every 5 days once, or other than change dressing in soakage or any solid will happen. That time also will change the dressing. We are using chlorhexidine attached dressing for central line dressing. Clean the bionectar or clave connector with alcohol swab whenever handling the central lines. Frequent hand hygiene and minimal line handling will follow. It is help to prevent the central line infection. Changing IV tubing every day once. While taking the blood sampling, fluid to be stopped 30 minutes before, and sample are collected after 3 ml of discarding the blood only. Then only sample are collected for investigation purpose. Sample are not collected from line with lipid, TPN and cyclosporine infusion are on board that line not using for collecting sample blood sampling. Then other than performing hygienic care. While handling the patient, we are doing frequent hand hygiene and following neutropenic care, and some low count measurements are followed our patient. Sponge bath are given at twice a daily with sterile water and antimicrobial bath solution are used and used to our patient and give the sponge bath. Chlorhexidine mouthwash is used for mouth gargling to prevent oral mucositis and infections. Sitz bath compulsory 2 times given for our patient. Fusarin ointment are applied in both nostrils to prevent infection. Candid mouth paint also applied in tongue. Then Metrogel DG float applied in gums to prevent gum bleeding and also povidone powder are used under underarms and folding areas. Uh, Triple cream and nip care are also applied in if any anal ulceration or cut are present. That time only will triple cream and nip care are alternatively used our patients. If some patients having skin itching and rashes are present, that time we are using liquid paraffin and efficacy cream alternative we are applying. It will help to patient to reduce rashes and itching. That's all, ma'am. Those care are we are you followed in BMT patients, ma'am.
Right. Thank you, Mahalakshmi. Dr. Amreen, I wanted to ask you from the nursing perspective as well as the severity perspective, would you like to tell the attendees what is the difference between autologous HSCT versus allogenic HSCT? What is the difference in the usual infection control, severity of the procedure, so that people understand? You talked extensively about the allogenic transplant in the AML. So please tell about the other part of transplant as well.
Okay, so just in terms of autologous transplant, we're giving the patient's own cells back to the patient. With sort of one of the complications of allogenic transplant, which is graft versus host disease. Of course, that you wouldn't see in this cohort, basically because you are giving the patient's own cell back, so they won't identify it as foreign. Now, in terms of complications that we see, I think the first aspect of autologous transplant becomes getting those cells from the patient, because we're going to take the cells from the patient before we sort of give the chemotherapy. And sometimes this process of taking the cells from the patient, because these children have already received chemotherapy, may end up being 1 or 2 cycles. So it's a lot of sort of nursing support to parents, to the child, especially during the procedure when they undergo this harvest. Now, some of these children are very small, and harvesting these children ends up being a 4-5 hours process, monitoring them during this date, especially because during the process of harvesting, you have to monitor blood pressure, heart rate, a very difficult task which nurses do really amazingly. That's the first aspect. Secondly, when you're looking at chemotherapy, you of course do use toxic chemotherapy here also. So you're going to see mucositis, but they do have cell recovery faster, they do go home faster. And the infections you see in this cohort is relatively less than what you would see in the allogenic cohort. Now, another important differential would be the most important infections you will again see would be bacterial. So you're still worried about those gram-negative bacteria that you can see, but it's very, very rare for you to have a viral infection in this cohort. So once they've got engrafted, they've gone home, they are relatively ones who don't cause much trouble and do really well.
Right. So definitely, I think it's easier on the patient, parents, and the nursing staff and the doctors to do an autologous transplant as versus an allogenic transplant, which also requires a very prolonged follow-up because of the risk of GVHD, as Dr. Amreen mentioned, which would not be there in a child who is getting autograft, which is usually for solid tumors. So children with Ewing sarcoma, bad Ewing's, bad disseminated neuroblastoma would end up getting autologous hematopoietic stem cell transplant, or sometimes high-risk medulloblastomas might be getting that. And they would have the procedure. Once they're engrafted, they're mostly done with the procedure. And we usually don't see a lot of concerns subsequently. So, but that is very different from an allogenic transplant, where definitely a long-term follow-up is required for graft versus host disease, complications, graft slippage, etc. So thank you, Amreen, very much. And do we have any questions in the chat box as of yet? It's actually a difficult topic. It is something which is being done at a limited center, and not all nursing staff would be very exposed to doing transplants. So giving chemotherapy for whether for transplant or for any child with malignancy is kind of similar, but definitely the complications are more because the chemotherapy is more heavy duty, as Dr. Amreen has explained. So if anybody has any questions, please do post in the chat box. Hi, Dharini. Good to see you again and Happy New Year. Do you want to chip in here?
Yeah, sure, ma'am. So, thank you, Dr. Amreen and Ms. Mahalakshmi. So, I missed a part of Amreen's talk, but I guess I had few questions to both of you, maybe. So, there are some things like melphalan is a drug which is used only in transplant setting. So, there is a practice that the patients are made to chew ice cubes during the melphalan infusion. Apparently, it's supposed to reduce toxicity. So is that something that you have also heard or you do in your center?
So no, we're not doing chewing of ice cubes for melphalan currently, but we have occasionally used ice cube for mucositis in older children who feel more comfortable in terms of when there is significant discomfort in the mouth, but not just for melphalan chemotherapy. During the infusion, I feel they tolerate it pretty well. Of course, the mucositis is severe any which ways when you're using the combination of busulfan melphalan for these solid tumor patients.
So actually, Dharini, that's a very interesting point you've raised. Do you particularly use this practice? Because we
Ma'am,
often
I
on
haven't
discuss
been
this.
trained that way, but in our institute, Ramchandra, currently, because it has been used in adult patients, so the same has been extrapolated by the staff to pediatric also. So those who can actually do it, but children, of course, get excited with the eyes, but I don't stop that. But the very young ones are not getting it anyway.
So have you actually seen a difference in the degree of mucositis they get? The
No,
ones who
no.
try versus the ones who don't?
No, ma'am. I mean, at least in pediatric cohort, no, I haven't.
Okay, because we do discuss it off and on, but most of the children getting the autologous are kind of neuroblastoma is the primary cohort, and they're like tiny most of the times.
Yeah.
So it doesn't often happen. And Amreen, do you do drug levels for busulfan at your center, or how do you decide to?
So no, we're not currently doing drug levels for busulfan at a center. I think it's available only in a few centers in the country currently. What we're using is there is a guideline which is weight-based. So just to reduce toxicity through that way, we're using a weight-based.
Right, because I think busulfan drug levels are difficult across the board and not easily available. Not sure which center is doing it in India.
I think CMC has it, but I may be wrong.
Okay.
Yeah, CMC I think has one. So the other point is regarding the BMT, the infusions that we make. So many things are time bound. So the infusions, the cyclophosphamide, the mesna infusions, the tacrolimus levels, and exactly taking the time, trough levels as per the timing, and the methotrexate for the GVHT. So many are time bound. So this nurses have to be really in line with us to actually not miss out many drugs. So there are many nurses who have actually say that day plus one, this drug has to go, day plus three, this drug has to go. So there are actually many nurses who actually remind us that you haven't charted this, you have to do it. So, so the thing is, how do you ensure, Amreen, that this happens in your center? So do you have a written protocol, or how do you go about it?
Okay, so the first thing is even if I have a day plus 3, day plus 5 drug which I'm giving, it's already in the transplant schedule. And a copy of that is in the patient's bedside. A very interesting point, actually. Our nurses also pick up things and tell us, but we do also have our chemotherapy dosage cross-checked by nurses. So when a prescription is made, all the nurses are trained how to make sure that the dose that has been written in terms of even for body surface area or etc. is the correct dose before they actually go and prepare it. I think just to add to that point here, then again, it becomes important, especially when you're using a Hickman line, that when you're doing trough levels for drugs like cyclosporin, because cyclosporin can tend to stick to the lumen of the line. So there is one dedicated line through which the cyclosporin goes, and there's the other one lumen through which the cyclosporin goes, and the other lumen is used for collecting the sample. And it should never happen that you end up doing it the other way around, because if you give the cyclosporin from the lumen from which you're collecting levels, your levels can be erroneously high. So, and cyclosporin or tacrolimus, very important drugs for GVHD. So a very crucial part here in the management becomes nurses ensuring that they give it correctly. Timings, we do have it fixed for drug dosages, for drug levels. So it's steady throughout the unit. We use more cyclosporin than tacrolimus. So it's twice a week, Monday and Thursday. It's a 9 a.m. sample. So then it doesn't get missed because everybody's levels would be going. And they've sort of color-coded the lumens. Of course, lumen come in two colors. So there's red and white. So then, for example, if you're giving it through red, so it's going through red for all patients, and the levels are taken from white for all patients. So it again becomes a standard. So then error reduction happens. But of course, it's all nursing based.
True. So the clear-cut protocol charting and of course ensuring that every day is a job of the doctor. But as I said, the nurses carry an equally important role in this situation. Another point that I wanted to make is a transplant is one situation where we need to be really careful about transfusing the blood products, making sure they are irradiated. And sometimes if this is a ABO incompatible transplant, like the patient recipient is one group and the donor is one group, then we always have to be careful about even starting from writing the form for request. So it always carries a confusion at multiple levels. So the person who is actually taking care at bedside to the person who is actually doing cross match in the blood bank, the person who is receiving form. So I mean, it's not easy for everyone to understand the concept. So we have to have clear policies. So in our hospital, we always say post BMT in the top, and we write this donor patient group, and then that we request this group, particularly this product. So we write each and everything we write. Of course, we need to fill 3 forms for every blood bag that we take. So it's a lot of work for our juniors, but still we have to do it for the safety of the patient. So that is something, and we have had errors, of course. Nobody can be foolproof. So we have had errors once because of the mismatch thing, and the patient has had a jaundice, and it was towards the engraftment. So we were confused if it was liver GVHD, or only later we realized we have actually given the alternate blood group, which has caused an acute jaundice, which later settled. So if you have any points on that, so the nurses have to be really careful regarding the donor group and patient group, and what blood group, what product, what group we are going to transfuse, and what are all the precautions that should be given. So if you have any comments, please.
A very important point, I think. So the 2-3 things we try and do to reduce errors here. One is that our transplant schedule has like a column or a box, which basically says that for this child, this is the red blood cell group, this is the platelets group, and this is the FFP group, which needs to be there. And that's in the part of the transplant schedule. So, and that's by the bedside. So if you're not sure, you just open it and have a look. Second would be the blood bank would have a copy of the schedule, and we have sort of an Excel sheet which basically has those details which is shared between the teams. So it can be accessed from the desktop for everybody, so you know that what is the information there. And the third thing we try and do is that our transplant prescriptions, the blood and platelet prescription, we individualize it for patient. So you get a typed blood prescription chart, which basically, of course, has the patient name on it, typed and the hospital number, but it also has details like this is the patient blood group, this is the donor blood group, but the blood you need to transfuse is this. What do we want? We want SDP, R or RDP. Is it leukorebleted, non-leukorebleted, irradiated, not irradiated? And because it is typed, I guess that helps reducing errors. That's done by one of the senior members of the team, just to make sure that that is foolproof. And then it can be printed for the child again and again. So it just makes it a little more easier. It's very important for the nurses to know this, because for them, that if you go and ask the patient's blood group may be different, but the blood we're transfusing would be different. And important to check the compatibility on the form when it sort of comes to them. So yeah, I guess all centers would have different ways in which they're trying to make sure that the errors do go down. But having something which is documented and making sure that the document is by the bedside, I think that makes it a little easier for them to understand.
Yeah, completely agree. I mean, we have in fact started telling the parents themselves. Most of them are sensible, so we'll tell them if it's blood, it should be this group, so that they also keep a check, third or fourth check probably, so that the mistake doesn't happen. So that is one thing that I wanted to highlight. If there are any, Richa ma'am, if you have any comments.
There is a comment in the chat box. So somebody is saying they would like to get information regarding lumen infection and antibiotic lock and when the line can be reused. So would you like to comment on that, Amreen, Mahalakshmi, either of you, please? Amreen, what is your take?
So, very, very, very interesting question. I think when you talk about lumen infection and using an antibiotic lock, I'm assuming that you are talking about patients who are neutropenic. So, technically, neutropenic in transplant, meaning WBC 0. And at that point of time, if you are suspecting that this is a line infection, which is not really very common, it's more likely to be a gut infection, which has then sort of come into the bloodstream and then gone into the line. Antibiotic locks we've used, we tend to use an antibiotic lock for 5 days, recheck, reculture, and see, and if the growth is still there, then the best option would be to get the line out. But when you're talking about antibiotic lock, of course, there's very straightforward guidelines into which organisms there's no point doing an antibiotic lock. So if you picked up a candida, don't try and giving an antifungal lock. It's not going to work. If you're picking up Pseudomonas tends to form a biofilm on the lumen, so very less likely to work. So certain organisms, there are recommendations not to use an antibiotic lock. Certain organisms are recommendation you can try with an antibiotic lock and see if it works.
Right, very true. Certain organisms, you just have to take the line out if the line is growing something. Otherwise, you run the risk of child getting sepsis and succumbing to that infection subsequently. Mahalakshmi, would you like to comment on the practice in your center? Do you use antibiotic lock? And what are the drugs that you use?
Yes, ma'am, sir. We'll remove the line only, ma'am. We are not using, ma'am.
So any organism grows from the line is removed as a practice. Is that what you do?
Yes, ma'am. We'll
Okay.
remove the line only, and second line, new line inserted, then only we'll remove, ma'am.
Right. So good to know. Obviously, every center will have their own practices. Sometimes it's difficult to get the line in depending on the age and the situation of the child. And if the child has a lot of cytopenia and if the line is essential at that point of time, and if it is a situation where the line can be salvaged, then I think people might want to try to salvage the line. And obviously, if there are specific organisms, as Dr. Amreen has mentioned, or in specific situations where the child is already showing feature of sepsis along with a line colonization as well, you would want to remove the line. So I don't see any other questions in the chat box. So I think this has been a very interesting session. And thank you very much to Dr. Amreen and Mahalakshmi both for being here with us today and telling everybody about care of children who undergo hematopoietic stem cell transplant. So the YouTube link for the webinar will also be available soon, and which we'll see, which we'll inform you about. So thank you once again, and we will update on the next session for February on the WhatsApp group. So thank you, Amreen. Thank you, Mahalakshmi.
Thank you, Tarun. Thank you.
Thank you, Amreen. Thank you,
Excuse me,
Mahalakshmi.
Dr. Jain.
Hello.
Yes.
Yeah, we have a feedback link I have pasted over the chat so the participants may find the link and join submit the feedback form.
So, thank you. This feedback is for the attendees.
Yes.
So I think please also post this feedback on the WhatsApp group so that
Sure,
whoever has attended can fill it up there. And I request everybody who is attending the session to please click on the link and post their feedback. So thank you for that, William. Thank you again, and bye everybody. Looking
you.
forward to seeing you all next.
Thank you.
Bye.